So good afternoon, everybody. And for those of you who are new and who haven't attended the webinar in our first series, I'm Kaushik. I've been hosting a few of these over the period of time. So today I thought I'll start off this lovely afternoon. It's a bit wet up here in Bristol, but I don't know how it's at your place. On a bit of a philosophical note, I just put a quote from Steve Jobs, which I'll read out for you. It says, "Don't let the noise of others' opinions drown out your own inner voice. And most importantly, have the courage to follow your heart and institution. They somehow already know what you truly want to become. Everything else is secondary." I thought it's a bit relevant because I think there's a lot of noise around the space at this time. There are dentists who are doing NHS dentistry, there are dentists who are doing private dentistry, and everyone is trying to say something which gets all of us confused. But at the end of the day, we as dentists, we just need to understand what we stand for and what is our main purpose. So I was just trying to Google a definition for the dentist, and this is what I found. As a dentist, it says a person who is qualified to treat diseases and other conditions that affect the teeth and gums, especially the repair and extraction of teeth and the insertion of artificial ones. Because today's discussion is more about that last part, which is called insertion of artificial ones, is where I thought this definition becomes a bit more relevant. And a lot of the dentists whom I speak to, especially in the UK, start to discuss about what options they want to discuss, what they want to know. Does dental implants become an integral part of the discussion with patients, so on and so forth. Our main objectives at Dental Root is to build a dental community with the aim for co-discovery of technology, treatment, and processes, which will help us to provide oral health, covering our patients' needs, which is what we always say, patients' needs, and also what we forget is the wants, because for a lot of patients, it's just not the needs, but also the wants for their functional and emotional well-being. And a lot of times we forget about it, trying to chase our UDAs and our basic criteria, which keeps getting discussed all the time. So on these lines, I wouldn't take much time today because we have an amazing speaker in Dr. Nigel Saynor to discuss the importance of dental implants in our day-to-day practice, which is what the whole objective of today's discussion is. And also he will be the best person to explain why learn the art of dental implants on a neutral platform. And hence it's easier for all of us to progress to being an expert in the field, as against just follow a company, follow every time. When I first started doing implants, when someone asked a dentist, what implant are you placing in this treatment? Rather than trying to talk about the shape of the implant, the surface of the implant, what are the criteria, they try to sort of look into choosing an implant. It literally used to go into a brand. Or I'm placing an Ankylos implant, I'm placing a Noble implant. And probably this is what we like to disrupt and say, we are dentists, we choose the implant, and the company doesn't ask us to choose what we should put. With those lines, I'm introducing, and it's a big privilege for us at Dental Roots to be introducing Nigel Saynor. He's worked very closely with us over the last few months in terms of trying to grow this kind of platform where we can train as we go forward and co-discover the importance of insertion of artificial teeth, as I said in my initial discussion. So Nigel, thank you very much for coming today. And I would stop my screen at this stage and allow you to take over and then take the mantle forward.
Kaushik, thank you very much for your kind introduction. Let me find out my way through this and see if I can share my screen here with you. Share screen. Am I sharing with you now?
Not yet.
Hang on. It worked earlier.
There we go. Well done.
There we go. Yep.
Hang on. Are we all happy with what we're seeing now?
Perfect.
Perfect.
Stepping into dental implantology. Why is now the best time? And how do I go about doing it? Now, this is a topic which Dental Roots have asked me to sort of speak about. And it's quite honestly, it's not something I've ever been sort of asked to do before, is how did I get involved with dental implantology? And the worrying thing is I have to actually cast my mind back over not just years, but decades to come across the answers to this. My first involvement in implant dentistry happened a significantly long time ago. And if I can get this to advance, 1983, which I guess was probably long before most of you were born, was my first foray into doing a dental implant course. And it was part of the IMZ Freelit course that was run by Axel Kirsch. And this was back in 1983. Really, dental implantology in the UK was completely and utterly in its infancy. I had heard of a few people doing some work with Professor Brannemark's system. Based in the Northwest, we had quite a big prejudice really towards IMZ through the University of Manchester and the Freelit 1 and 2 system. And because of that prejudice, really, most of the courses run locally because at the time there was, quite frankly, there was no structured education available in any shape or form. And you sort of like today, the whole thing, and today, this is an example of the way forward and how you can have good structured learning. But if I tell you about my own pathway, this initially started off as a Saturday lecture. And this is the one that everybody frowns upon and thinks, oh, Saturday, do one day, and you feel competent enough to do implants. Well, I'll be honest with you, after doing one day, I felt absolutely terrified of doing implants. And I thought, I need to know a little bit more about this. So I went on a 5-day course over to Germany, and I thought, let me whet my appetite. Let me see what we can do, because I felt really comfortable making full dentures for patients. But when I got out into practice, having worked in the hospital as a house officer in maxillofacial surgery and in prostho, I kind of felt that there was a little bit more that I could add to patients, because I came across extremely challenging cases where no matter how hard I tried with anthropoidal pouch techniques and closed mouth impression techniques and all sorts of these bits and pieces, I couldn't get those dentures to work, the lower denture to work for the patient, couldn't get any retention. And it felt really that I was faced with looking after what I deemed as dental cripples, because most of us, hopefully listening or watching or whatever involved in this group today, we've got our own teeth. We take eating, chewing, smiling, all the functions that you can do with your mouth, whatever that is, talking, speech, all of these things, we take totally for granted. Whereas you see patients, and most of you have come across this, who are totally incapable of functioning, and their lives must be a misery. And I thought, let's do something. Let's see what dental implants can offer. And I thought my initial reaction was, let's do something that just retains implant overdentures, and mainly just in the lower intraforaminal region, which had amazing level of success. So in 1984, I had my first case where 2 implants were placed intraforaminally, and I constructed a bar overdenture and did the restorative part only. I kind of shied away, even though I was competent at doing things like apical resection of teeth. I felt comfortable removing roots. I felt comfortable doing lower eights. I had no issue with any of these things, but implants, for some reason, I thought, wow, this is more of a responsibility that you've got to get the infrastructure, you've got to get the superstructure. And I thought, originally, let me concentrate simply on the restorative side of it. And I still see this patient from 1984. They are now 90 odd years of age. And their response to me is that having this treatment done, which I've seen them several times to remake dentures, obviously, having this treatment done has changed their lives. And you know, to hear those words when you say, you've changed my life, is a significant thing that I think most of us in the profession take for granted, because we look at it and we think to ourselves, this is, you know, it's easy for us. It's not terribly complicated for us to improve things like this. It's your job. So you take it for granted. And I think that is something I did, that I thought, well, I'm only doing my job, aren't I? So in 1986, I got my first single tooth implant to do. And I didn't do this myself. Actually, no, I did do this one, because in 1984 and 1985, I did a few other cases, and I had some single teeth, which I have to admit, aesthetically were appalling. They were just dreadful. I had an oral surgeon colleague place implants for me, and every single case that came back, I had failures of implants before I loaded them. I had implants that were placed in the wrong position. They looked aesthetically dreadful. Functionally, the positioning was just so bad. And I must admit, it gave me the drive and the impetus to say, right, if a full-on max fac surgeon who I've watched do the 4 osteotomies and all sorts of stuff can do it this badly, surely I can't do it much worse. And I got involved, having done all sorts of training courses, and it was a cadaver course ran by a guy called Michael Block over in Chicago that really moved me forward. And at the time, you couldn't go anywhere to learn about it. You had to travel the world. There was no one specific place, one specific destination you could go to. And that really transformed the way I started working within implant dentistry. I got busy in 1986 because I saw what I could potentially achieve. And the diagnostic tools that we had in those days, none of you will be thinking today of doing a ridge map with a pair of pliers that you can measure the ridge, but this is what we did. We had models, we split them, we pre-indexed the model from the ridge mapping. I made surgical guides working backwards with a rod and tube in them so that I could accurately place where my implants needed to go. And this was really basic level of diagnostics. We weren't really sending patients away for CT scans unless they were really quite a complex case. And at the time, the cost of CTs were prohibitive. It was like £800 to £1,000. I remember it even back in 1988 on a case where I did my first full upper arch. And it was just scary. You know, the first restored full upper arch I did, I got a guy, a lovely guy from Ireland, a guy called Spencer Wolfe, to do the surgery. And I had him in my office as my mentor. I watched him, I watched what he did, I watched his placement. And do you know something? All the planning that I put into a single tooth and I was going to place into doing a full arch restoration, he didn't do any of this. He just said, oh, yeah. I've made a guide for him, a stent, everything. He said, fine, don't worry about it. I'll just place them. And he went ahead, placed what he did. And the nightmare to try and treat them was just, restore them was just unbelievable. So again, that was a valuable lesson learned. And I thought, I've got to go my own way. Place, restored a full lower arch. And I felt like I wanted to high five everybody in the car park. It was unbelievable. I did my first ever GBR on a single tooth. This was when, I don't know, about 3-4 years after BioOS was first released, which was the product I used then. And I thought, how on earth can this work? And you know something? It kind of blew me away what the human body is capable of within its healing capability. By following simple, basic principles, you're looking at dental anatomy, for example. You think about three-dimensional placement of your implant. Where does it need to be? We know full well from the biologic width that if we prepare a tooth to impinge upon this biologic width, you're going to see movement of bone and you're going to see movement of the soft tissue away from the preparation that we've done. Thinking about dental anatomy, you sort of get into the thought process of how the tooth works. We've all seen how you can create a beautiful ovate pontic with a bridge by just literally shaping the base of the pontic, which then miraculously brings back those interdental papillae. And I've always kind of thought to myself, you know, I need to bring these two pieces of tissue back together. And then having sort of analyzed these two pieces of tissue, I realized, well, you've got a lot more going on than this. And you have to think about the support of the tissue, you know, the interdental cowl between the two pairs of papillae that we have. And it was all these sort of thought processes developing, coming through the diagnostics that took me to a different place, really. And I felt so much more confident. So having looked at this 6 years after starting, I placed and restored my own full upper arch, having done an absolute, I don't know, maybe 20 cases restoratively of restoration on full arch implants. The lower is so much easier to deal with. Predominantly, we're working intraforaminally. You can go all on 4 design quite easily there because, you know, the density of bone, I always liken the intraforaminal of the mandible as mahogany. It's great bone. Sometimes it can be too good in that when you prepare your osteotomy, you see no blood emanating from that hole and you think, damn, if there's no blood there, I'm not going to get good osseointegration because you need the blood to bring the nutrition to it. But that's for another day, how we can talk about what's going on there. 1992, having done quite a number now, I would say probably 25, 30 full arch restorations and avoided, we were doing sort of like an all on 4 design before I knew what it was, but it was never on 4 implants. It was always with a bit more than that. Utilizing pterygoid implants and implants around the premolar region. And prior to 1992, if the maxillary sinus was huge, I would avoid it, send it off to one of my local oral surgeons. And none of them wanted to share because they always made it so much more difficult looking than it really needed to be. Every MaxFat guy that I went to see to teach me how to do sinus lifts were harvesting bone from the iliac crest. And I was thinking, well, I don't have the privileges to go into a hospital to do this. And the other thing I also thought about is the morbidity of patients who'd had this iliac crest done. They were moaning like hell about this procedure. And then we heard about the internal sinus lift, Hilt Tatum's work, and stuff like that, similar to this sort of time, where we were utilizing different materials in the sinus. And I remember doing a course with Richard Lazara on sinus elevations, utilizing BioOS. And I did my first sinus lift, and I was absolutely petrified. I had probably gone through two, maybe 3 dozen eggs, trying to practice doing the whole. And when I felt comfortable to do 12 eggs in succession of removing the shell without perforating that membrane lining, I felt comfortable to go ahead. And do you know something? The first one we did, boy, was that so fantastic. I couldn't believe the result that I had achieved. I even showed my own mother the x-ray and she said, "What is it?" She's not a dentist, obviously, but it was just crazy. Then I went on to bilateral sinuses, and I also did my first ever block graft back in 1992. So things were starting to move very, very quickly, and I felt very, very confident with what I was doing. In the year 2000, prior to this, I had used a plethora of dental implants. I had been lecturing for Nobel Biocare, for Freodent, and for 3i, which was quite a rare thing in those days because you either had one camp and one allegiance or nothing. And then my really good friend Ashok Sethi, started looking at the Ankylos system. And he said to me, "Nigel, you really need to see this." I went out to Germany to see a guy who's a very good friend of mine still, a guy called Michael Stiller, who is an absolutely awesome surgeon. You don't really hear much of him on the lecturing scene, but he was doing sinus lifts with endoscopes and all sorts of stuff, lateralization of IDs and all these things. Such a talent and a gift, it was unbelievable. But what I saw was a system that kind of blew my mind. And I started working with this, knowing that this was really well ahead of its time. It's a bit like, I don't know if any of you guys have ever owned a Porsche 928, an S4. Well, I had one up until recently. And that car was 20 years ahead of its time. Like a lot of various cars available today and technology that there is in them, you're thinking, it's not similar to anything I've ever known in the past. But anyway, moving forward from that, in 2008, I got invited, I completed my master's in dental implantology at the University of Manchester. I was invited in 2005 by the team, Professor Coulthard and Marco Esposito, who were setting up a course in dental implantology, a master's degree at the university. And they asked me if I would become one of the course tutors for the clinical side. And in a moment of absolute weakness, I said, well, what about the possibility of me actually doing the master's as well as teaching it? So I was very, very fortunate that I could do both aspects, and I was exempted from some of the clinical stuff, but I still had to present cases, etc., of which I had hundreds to choose from. And I was always trying to persuade my fellow students, my postgrads, to try and buy these courses off me at a very extortionate rate, might I add. But nobody succumbed to my bribery and corruption. Fortunately, they did their own thing. Also in 2008, I completed a Bon Solon course to become an expert witness. And I did my first ever medico-legal opinion on failing implants. And I thought, this is going to be a big problem going forward. And a lot of the issues that I saw was all down to very bad planning and very bad execution of the work that we were looking at. And I think also the patient expectations started to get to a level where they wanted something better than just replacing their teeth. Oh, we're going back. Hang on, sorry about this. Bear with me 1 second. Pressing the wrong buttons here. Let me catch up. I do apologize. But like I was saying, patients' expectations got so much more demanding. Aesthetic demands were much higher. And in 2010, being a key opinion leader for Dentsply, I think they had acquired Implant at this stage. And I did my first ever guided surgery case. And the guided surgery I'd done was a bone supported guide, followed by a tooth supported guide. I became extremely tempted to do a soft tissue supported, but I went to a big meeting, Nobel Biocare, where they showcased, I mean, it was just a fantastic setup. It was just awesome to watch. And they showcased a surgical procedure where they utilized the Nobel guide and did this flapless surgery. And to show off, they then reflected the flap having placed the implants. And alarmingly, 2 of the implants were outside the bony housing. And I thought to myself, this is crazy. Why are we so scared of reflecting a flap? Put the surgical guide onto the bone. If you have it on teeth, solid, great. If you have it on bone, solid, great. Go with it. Otherwise, soft tissue guides, for me, are an absolute no-go. And to this day, I still concur with that, because I think really even with the technology that we have today, I don't feel confident enough that the soft tissue compression, or whether there's any movement or whatever in the guides when you're placing them, that the accuracy of it is there. The only time that you would ever consider it is if you have a serious case of osteoeconomics. Normally, osteoeconomics means plenty of bone and no money, or plenty of money and no bone. And if you have a lot of bone available, then probably you can do a soft tissue supported guide, but not on my watch. I don't feel comfortable with that. 2018, I did my first ever PRGF case, and we routinely used the patient's own blood to enhance our healing. I had resisted this for some time because the technology had been around for quite a while. And I thought, why not? And the results we get are pretty significant. I wouldn't say the healing is any better. And I think that's probably down to the fact of surgical technique. And I'm not trying to blow smoke, at my own derriere. But if you are treating patients who are awake, treating patients who might be sedated, I feel that you treat them with a little bit more respect, and you're not as ham-fisted as when I used to work in theatre and dragging people around, etc. And you could see it in the face of oral surgeons, how they use mallets and stuff. It's just scary, but it kind of worked. Now then, what are the aims and objectives that we have when we're looking at implants? Who can have implants? Well, ideally, anyone potentially with a space or lack of teeth can have implants. If you would consider that you have tooth number 8 or 9, that's the central incisors, utilizing the American system because I lecture a lot in the US, 2-1 or 1-1 or 2-1, and you've got virgin teeth either side, would you be happy to sort of like prepare those teeth, knowing full well that once you've removed that dentine and enamel, that there's no way you can put it back, and that the restorative stairway literally leads one way. You know, once you put a drill into a tooth, you can't ever bring that back to where it was before. And we then have to look at these cases and think, is it ideal for an implant? What would be your first restorative case or first placement? You then have to go through the procedure of the restorative side of things, which is a good step-by-step impression procedure, having obviously in the first two parts gone through the diagnostics, which this course will touch on or spend a great deal of time on that aspect of things. But going through the procedures, and everything is a bit like eating an elephant, I think. I like elephants, but I couldn't eat a whole one in one go. So do it a little bit at a time. And it's not difficult then. Break it down into a structure. And the course will give you this structure. And the reality of it is that you follow protocol and follow structure. Now on our return back to work, we have SOPs, our standard operating procedures. It's a standard operating procedure for an impression technique. It's a standard operating procedure for fitting the abutment and the crown. We've got to look at the occlusion and cement or screw retention. My preference being to go for screw retention because excess cement is an absolute nightmare and a major cause of cementosis, which is peri-implantitis. If you're not competent on part or any of this aspect, look at referring, look at working with somebody. And of course, at the end of it, you've got to look at the cost of treatment. One of the things I've said to a lot of the MSc students at Manchester University is that they've tried to entice a patient to have treatment done at a grossly reduced fee. And the reality of it is, if this goes wrong, you are there carrying the can for that reduced fee. Charge a normal fee, follow the standard operating procedures, and do it right. Things will go wrong, as they always do in implant dentistry. In fact, dentistry itself, things go wrong. And we know this, and we prepare for it. What we do know that if things do go wrong, as a caring profession, we will always do our utmost to put things right. We won't always be able to avoid problems, but we will do everything in our capacity to put it right. And that's an important aspect of what we do. So, implant systems, I mean, I dragged this out of the archives as a very, very old slide to show this is 30, 40 years ago. Things have changed, not a great deal. The root form implant is here and it's here to stay. The materials of construction you can see on the top right and the bottom right there. Ceramic implants, well, we have ceramic implants today. We had them in those days, but they didn't work very well in those days because they weren't strong enough. We've got different types of connections going on, different types of threads. Look at the bodies, how they're staged and stepped, and all sorts of different things. What are the facets then of a dental implant? Well, the implant itself is obviously just a mechanical root. And all it does is facilitate us to place what we would call an abutment, which is the connector that connects the implant to the oral cavity, onto which we can attach a crown, a bridge, full arch restoration, or an overdenture. The important thing when you look at an implant is quite complex, really. You've got to look at many, many aspects of the implant in order to make a decision what implant system you want to go through. And again, this is the kind of thing that will be really extensively covered on the course. Connection-wise, for me, the only way forward is to use a conical connection. I don't believe anymore that geometric connections, i.e. slots, hexagon, any of those connections really have a place in modern dental implantology. And I will explain a little about it. And obviously, again, on the course, this is something that you will be equipped with to learn what to do. Who can have a dental implant? Well, essentially, any patient who will have a missing tooth and sufficient bone. If we look at this clinical case, we have the upper left central incisor, which has a root filling in it, and it's not particularly obvious on this screen. The patient was kicked by her little girl, accident totally, not deliberately, and she's fractured this tooth just at the tip of where that post is. She's a TV presenter. Says to me, I am presenting the news every night. I don't wish to look any differently when I leave your office. On that basis, just try and do your best. And I thought, well, there's no pressure there then. This is the result that we achieved for her, which I think is a very acceptable result. Any patient, like I said, can have teeth placed in. We can see bridges in there, full arch restorations, the whole gamut. This is a Syncone case, removable on various abutments that are specifically made from Dentsply, the Ankylos system. Make sure before you embark that you are covered. To follow the GDC guidelines, working with standard group established by the GDC, only looked at placement of implants. ADI guidance is a good guidance as well. They're constantly being changed, these guidance, and really make sure that you're compliant. Audit every single thing that you do. If you notice my pathway, I had the various dates of what I did. It's a bit like a comedian having his book of jokes all written out. Document, 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 document everything that you do. If you ever get into difficulty, into trouble, you have documentation to prove what your learning pathway has been. And getting involved with something like Dental Roots here gives you a very structured way forward to show that you have spent the time doing the correct training. It's a mentor-led system. With a mentor-led system, you are learning somebody else's experience, because experience is a collection of errors. You are better off collecting somebody else's than collecting your own experience. So look at the errors that other people have made, and boy, we have done them. The one who says, I've never had a failed implant, doesn't do enough implants or has only been very, very lucky. So let's look at your ideal first case. What is simple? Maybe a single premolar, an upper premolar, particularly if the sinus is well away, or a molar, something in a low lip line aesthetic area. Look at 3-unit bridges. Long span bridges and quadrants become harder when you're getting down to things like the aesthetic area, full mouth restorations. They are very hard. Don't underestimate how difficult and how easy, when you look at your tutors working and your mentors, how easy they make this process look. But trust me, it is the swan. At the top, it's all calm and serene. But underneath, where the brain is functioning, it is going at 300-400 brake horsepower. Everything is functioning at warp factor speed. So don't underestimate things. Again, looking back on why I chose Ankylos, it's all to do with this taper connection. And we'll see why that taper connection has a significant outcome to it. Is this an ideal first case? Well, I would say not. This was the TV presenter. If we look closely at something like this, we've got a medium type of gingival biotype. We're doing a socket sounding here. The only way I would advocate somebody that's 200 implants or less to place this is guided and to have a surgical guide made. so that you know precisely where the implant is going to be. Here, we did use a surgical guide, and if you look down into the socket, we've got a space between the facial aspect of the implant and the buccal bundle plate, the buccal bone, that bundle bone that we have as described by Jan Linde. Various sources have differing opinions as to what to do with this space. There is an awful lot going on at the moment about partial extraction techniques or partial extraction therapy. I am not a big advocate of it because it doesn't solve the problem that I perceive or see. What I tend to do is fill that space with something like an anorganic bovine bone that allows that bundle plate of bone to remodel. Now, because it's an anorganic bovine, it doesn't resorb, so it acts like a scaffolding. And that remodeling takes place in such a significant way that it assists long-term maintenance of this implant. So if we look at the abutment connection, and this was one of the first ever ceramic abutments, they hadn't even been boxed and labeled these. These were sent as a prototype, one of the first ever ceramic abutments that Dentsply made. And I connected this and used a second abutment as the duplicate, the lab analog. So I did never wish to interfere with this connection again. I had the confidence that the soft tissue zenith, despite the fact that I had sliced it with the periotome there, my mistake, you can see the errors, but I kind of knew what was happening. And what I also knew was where on the contralateral teeth is the contact area going to start. And because you can do a socket sounding, you can measure it. And you can actually then say to your dental technician, because we all know about Dennis Tarnow with Cho looking at the 5mm rule, that you will always get a papilla in that height. So they only looked at 30 odd cases to prove that point, which I think is staggering. But anyway, it works and it's a good rule. So we provisionalized this with a little bonnet that fitted accurately on the second abutment. And if you notice, the tooth is slightly short on protrusive excursion. You've got to, when you're doing an immediate total tooth replacement like this, keep it out of occlusion. And if we look on the palatal, on very heavy occlusion, we had this contact there. So we removed it and make sure that it was completely out. Notice that the provisional restoration forms a socket seal. So what it's also doing is not just sealing the implant and the bio-os in, but it's actually supporting the soft tissue. We know we've seen where we've made dentures that are gum fitted, that if you do the right preparation, which very few technicians today remember how to do a decent denture that way, and socket fit a tooth, where you put a slightly deeper groove into the facial aspect and taper it back, that you get a decent support of your soft tissue. And even with a denture that's removable, you can still create papillae. So think about the dental anatomy. This is it healing nicely. I feel it's quite a nice result. The patient was delighted she could still function. And papilla-wise, it's pretty good. It's not as good as what God created, but it's damn good looking at it as a whole. Now, going on to the final restoration, we can enhance that papilla a bit more. We can make it work a little bit further for us. Maybe if we were to be really critical, the distal line angle could be a bit harsher, which would have brought that papilla down to the lateral incisor a little bit further. But I think we had a very reasonable result. I like looking at them in black and white to see that the value is correct, and looking at them face on, magnified so the patient can see them. And at the end of it, smile line, it looks really nice. The papillae just sit where the smile line is. When she gives a full beam smile, which I asked her to do and send me a photograph, I was hoping that I could see a little bit of a smile, but I think in this case she got her implant surgeons mixed up. Anyway, looking at success is great, isn't it? We look at these cases that we have here, and you'd be hard pressed to find out where the implants are until you look very closely, and there are telltale signs of what we're looking for. But to get quality work that's lasted an awful long time is a bonus, it's a pleasure. When you look at something like this, you think, oh my God, what is going on here? Yeah, these are the kind of failures that I see. They're not my own work, by the way, but this is the kind of stuff that I get asked, would I repair it? I get asked too much, I feel, to repair stuff that could have been avoided. And I'm quite critical of some of this stuff, especially when I do medical legal work. If I ask to see the reports, which I did recently, and the notes were, mine aren't brilliant, but these were just appalling and gave no thought process as to what we were doing. So is this an ideal first case? Well, yes, on one condition. Yeah, you've all guessed it. Where's the mental foramen? If that is, when you measure it by CT, 25 millimeters away, then go for it. High five everybody in the practice when you've placed that implant, because do you know what? You're going to get a stunning result. You look at the crown behind it that's been there for 25 years. That the crown in front was a post crown that failed. But look at how the soft tissues are there. This was one of the first year students that did this. And it was so rewarding to see it. You see the recession on the teeth on either side, but nothing around where that implant is. 5 years later, I think he sent this to me. He was so happy with it. So what about a case like this? If you look closely at the x-ray, somebody's done a partial extraction therapy technique, or did they just miss out completely one of the roots? Well, the implant didn't integrate. And look at the crater that we have there. That was the amount of root that somebody had forgotten to do. And believe it or not, this person didn't even take a check x-ray. He'd basically done some basic courses, felt he was confident, had too much arrogance about the way he was treating things. And for him to pay me to repair this with a bone ring technique there was a significant impact on him, trust me. We look at these sorts of cases where really challenging situations, and I'm happy to do this kind of block grafting for people, where I will take a big piece of bone. I also use the Botis bone blocks provided by Straumann. I use PRP and PRGF there, and I'm happy to send these cases back in such a way that it makes it simpler for you to be able to place the implant, provided when I do these, I always insist upon seeing the treatment planning. And the other thing I ask people to do that I work with is provide a suitable placement guide. There's no point going to the extent and the trauma for the patient of having a block graft done and then to place the implant incorrectly. When you're on the virtual world, it's fantastic. The guidance, the digital pathway is there for you. Use the technology. This is the kind of outcome I took by not using technology. And look at the impact that we received here. 1, 2, 3, 4, 5. Yeah, 5 implants. Was it over the top? No, I don't think it was. Patient insisted on individual teeth. I knew within the ankylar system that I could get them to work well. If you look at the platform offset, it gives enough bone, blood supply to the bone, but it makes everything quite comfortable to work with. And that was a result that was, I don't know, 5, 6, 7 years later. We look at another case, fractured tooth. We know Garguilo's interpretation of the biologic width means that the bone will move away from that fracture, which it has done. What we can also tell the patient from this fracture is that because that bone is saucerized in the way that it has, it means that the final result will be slightly elongated. I can improve that for you if you wish by doing an orthodontic extrusion. But if the patient is in a bit of a hurry and not happy to go through with it, then maybe that's not the way forward. So we looked closely at this case where we did the same concept. This was one of the prototype A3 shaded abutments that Dentsply had released, or were playing with essentially. And we got a chance to be one of the first to use it. So we placed it as a one abutment and went through the process to restore that case. And if we look very closely at the result since 2003 up till 2011, and then if we look at the CT of the case in 2018, we can see that after a 15-year result, and the photograph, by the way, is 15 years old, how much bone that we have in there. Look at the way that that bundled bone, which is supported underneath it with bios that is probably 60% left, with then bone attached to it. You could do an ostel on this and realize that the osseointegration level is very, very high. But looking at the photograph, if you look at the lateral, the central incisor, just look up above where that gingival zenith is to the margin of the clinical crown, and look at the way that that's stippling. I was always taught when I was a student that the orange peel effect, the stippling, is vitally important to show gingival health. We even have that Sharpie's fiber appearing above where that implant is. And the reasoning behind that, if you analyze, the bone needs to be present for that Sharpie's fiber to attach to. And if you see it, it curves over the head of the implant. So it gives a slightly different direction as to the way that implant can go and the bone with it. And I see this regularly and routinely in an awful lot of the CT cases that I have. Excuse me. So if we look again, look closely at some of the evidence of what we've got here. Beautiful natural aesthetics. The crown on the lateral incisor, obviously you can see that that's a crown. There's a veneer on the canine. And on the central incisors, we have two beautiful, excellently contoured implant restorations. Adjacent implants have always been considered to be our nemesis, but if you follow the protocols, they work. This is a dental colleague of mine that came in, periodontal problem here, which is a bit surprising. I have to be careful when I present this in front of him. Particular problems going on. Did all our diagnostic work, looking at the models. A treatment wax-up. Don't call this a diagnostic wax-up, please, because I cannot diagnose anything from a wax-up. This is a treatment wax-up to demonstrate to the patient where the final result can be and where it ends up with his occlusion. And from this, I can provisionalize and create an end result for the patient that would be acceptable. So we had a shell made with an index in order to accommodate the positioning of it. We placed two implants. On the one side, we had a significant defect, but we managed to put a soft tissue graft underneath. You can see from the suturing. On the opposite side, there was less of a problem, so we didn't reflect a flap there. And then we basically just built up the provisional restoration. There are the two implants in place. And we went from here to there on day one, and then going through the process of making the final restoration. You can see good soft tissue harmony. It will improve on where that upper right lateral and central incisor are, given proper cleaning. But that's the kind of result we can get. Another really drastically difficult case through to a nice end result. A full arch case where we look at a few teeth that are present. We avoid here or did a small sinus tap. Actually, on one side, I did a full, it was just a sinus tap, which is a relatively easy technique to do, through to a final result there for the patient. That's the situation at 6 months. Again, the patient wanted as many individualized teeth as he could. And we look at the results, something in the region of, let me go back. That is 14 years down the line. And I love taking these photographs and these pictures. You can see maybe there isn't as much bone on the patient's, on the left of the screen, the patient's right-hand side. But in the center there, we've got really good bone adaptation going on. I love seeing adjacent implants. Dennis Tarnow said, show me 10 cases and that can prove the rule. Well, Dennis, there's 50 cases. I think that's great. Full arches. Let's get on to the difficult stuff, but this is so goddamn rewarding. Patients who come and see me with these, honestly, the gratitude for changing somebody's life from being what I deem to be a dental cripple, and the mobility in here was horrific. The number of patients I've seen come in with super glue attaching their teeth to their gums is staggering. And you can get some amazing results. This is the treatment wax-up that we did. We had a provisional situation which showed us precisely where we wanted to place the implants within the prosthetic envelope. It's all about planning. If you're going to do a veneer and your preparation doesn't allow you to put the final restoration in within the prosthetic envelope of where you wish to work, you will never get a result for that patient, ever. So you work within the prosthetic envelope. Right, the angles aren't great on some of these implants, but do you know what? We can overcome it by doing individualized crowns like this. And we can make it look quite pleasant, pretty, patient is happy. So review protocols, coming to a close here. 1 month is the normal that I see my patient after the fit, and every time we fit a restoration, whether it's a single tooth or a full arch or an overdenture, that patient sees our hygienist. The hygienist will teach them what implements they need to use to maintain that structure. And that is so accurately recorded because the lack of maintenance is the biggest problem that we face today. So 1 month, 6 months, and then annually, I see the patient for 5 years after the event at least. What do we look out for? Clinical observation, obviously. Check the occlusion, check the occlusion, check the occlusion, check the occlusion. It's a dynamic thing, especially if you have a different tooth to implant ratio. Massage the area around the implants. Some people say probe for inflammation or pus. I am not a prober. I don't think that probing, and there's some published work that would say don't bother to probe, looking for pus. Take periapicals where necessary, compare bone changes, and look at papillary changes. What are the keys for aesthetic, ultimate aesthetics? Stable bone volume and architecture. Number one, if you haven't got the bone, you have no chance on God's earth to get an implant in the right place. Correct three-dimensional placement of the implant. Digital pathway, when you learn about it, will throw you, it's crazy. It's amazing how it works. Adequate soft tissue volume and thickness. If you haven't got the soft tissue volume, the attached mucosa, you are looking for pain. Pain for you, not the patient, because the patient will get failure. And as the implant fails, they don't feel pain. It's only when they have to pay again that they feel the pain. Early or one-time abutment connection is brilliant. Transmucosal form and contours and material. We're in control of the materials that we use. Today, there's a massive drive on using zirconia for full arches. No, the bloody thing breaks. It's so technique sensitive on sintering and cut back and all this sort of stuff and layering. Honestly, there's a lot to be said about some of the old-fashioned stuff. Develop and maintain soft tissue volume and maintenance, critical. So look at some of the costs, the potential that you can do. We're not in this business as a charity. This is a business, but you know what? It is one hell of a business. It's like show business. if I had been a regular dentist, not that I am being disrespectful to anyone who's a regular dentist, at the age of 62, which I know you're all struggling hard to believe that I am, I would have retired a long time ago. This type of treatment, when you're doing something that's outside of the envelope of where your comfort zone is, and you start moving things forward, gives you a buzz. Financially, it also is significant. You can be looking at £400, maybe £500 an hour when you're doing your implant placement. And I'm not saying that financial should drive you, but it should be a goal, because I personally look at all these brands and think that these are significant, play a significant part in my life. And something that enables me to do this is to work with this company, Dentsply Sirona, and I do also work with a few others, Straumann, Antagir, but Dentsply Sirona has probably given me the ability to indulge myself, the passion that I have, and also going slightly further into my motorsport. It's an expensive hobby. People say to me, have you not retired yet? Well, the simple truth is, if I keep running this thing around the track, I can't afford to retire. But do you know what? I absolutely adore what I do. So on that basis, thank you very much for your kind attention. Can somebody, because there's my mouse, stop sharing. And I can hand you back to our moderator. And more than happy to accept whatever questions anybody has and move forward from there. I hope I didn't take too much time up. An hour is what I was told, and I hope I started on time.
Perfect. Oh my
Thank you
God.
very much, Nigel. Thank you.
Yeah, it was. I can't remember. I was just trying to remember if I could have got anyone else in this place to have explained what we wanted you to explain to all our participants today, who are especially coming from a general dentist background and who are trying to jump into this huge ocean of passion and the other things that you showed. Obviously, the Ferraris that you showed at the end is probably the one that caught my eyes the most, because that's where I want to be at some stage. But it was awesome, Nigel, because when we were getting into dental implants, which was much later than you did, we still had a few struggles, and then we never had the same level of support where people like you who have done it for ages could be so down to earth, explain it the way all of us could understand. One of my very good friends actually sort of taught me a couple of questions, which is probably the best questions I know in my life. And every time when I try to talk to people, these are the two questions I ask. One is with my patients as well. When they ask me, I think at the end of it, it summarizes to two questions. What is there for me and why you, right? So Chris says it as well. So I remember them so well every time, because this is exactly what, guys, your patients' overall complaint is all the time. It summarizes to the same two questions on what for me and why should I choose you. And you guys should probably be able to give them a very satisfying answer. Most times we guys confuse the first question of what for me to just be the needs of the patient, but we never understand the wants of the patient, because patients never are able to exactly put it forward in straightforward ways of what their wants are. It's specifically, if I give you an example, probably Steve Jobs knew what we wanted in a phone much before we knew what we wanted, even though we could sort of think and speak and discuss it over a glass of beer, but we really couldn't picturize what it was. It was for a techie like him to tell us what it was. And probably that's exactly what we as dentists are able to do to our patients to fulfill their wants. And on that basis, I'll come to your wants and needs and how we can help you to answer your patients' wants and needs. This is where the thing that you see on the screen right now is a certification in dental implantology course that we at Dental Roots have compiled for all the general dental practitioners who are wanting to go into the journey of dental implants, in the leadership of Nigel, and also the support from some of the best speakers in surgical and restorative dentistry. We have come up with a 6-month certification course, which basically starts to sort of highlight on what it is there to offer you, basically realize your potential and discover the next pathway. That's the first thing we all should do after what we heard from Nigel. And as we go into the next step of pathway, we should make the right connections, establish ongoing support, and take advice from people who know it the best and who have done it a hard way. We also should gain insights and also establish best practices, which is what we need to train ourselves into. Your chance to hear from an international rooster of speakers is when you get a chance to get a very good insight and start to establish a best practice. And that is what we are trying to sort of accumulate when I show you the list of speakers who will be there trying to help you. And this in turn will help you and benefit you from creating a very holistic, multidisciplinary approach. And that's the key. I think we got to make sure we understand all aspects of dentistry. And even for people who don't do dental implants, we all feel that they should have a very good understanding of it, so they can work with people like Nigel, where they take their help in those kinds of situations where they are referred, but we also understand what they have done to take things forward. Also, the latest technologies, techniques, and tools of the trade. This is the key. And the amount of technology that is starting to being put into healthcare and dentistry in particular is amazing. Nigel's spoken about a few. We are now sort of also training people on dental lasers, which is an amazing tool, which has made life so easy and which has made patient experience so wonderful, which will be a discussion for another day, obviously. And also at the end of it is that sort of a hand-on mentor-led training that we all need while we're learning things. So these are the key points that we are considered coming up with this course. There is the who and who of dentistry in the UK and around the world. These are some of the best speakers headed by Nigel. There is Sham, who is one of the best guys to talk about the ethics and the judiciary regulations. Tiruchalvam is a consultant in oral surgery. Ben Atkins, Anthony, Ben Roski, Graham, Luigi. I think you haven't heard Luigi so much. He is one of the very, very amazing speakers about digital dentistry and dental radiology. I haven't heard a better speaker than him. He's from Italy. He used to teach us when I did my master's in Italy. And then Ben White. Ben White is based in Southampton. He used to be my mentor when I used to start placing implants in the initial days. And Pawan is a dentist up in London who has created a wonderful digital workflow within his practice, which is an amazing sight to see, because every time I go to these dental shows, I struggle to get a good hang of a proper workflow, which we can integrate within the dental practice. And he's done an amazing job at that. David Wade, some of you might know, is a dentist as well as he runs his lab. So he has a good experience between digital dentistry as a clinician and as well as a lab technician. And then he's going to put his insights. And then my three close mates up there after that, who's helping us to run the show. And the last guy out there is probably the guy who will be your backbone and be there for you any time of the day. Chris is there with us, who manages all the problems. Whenever we can't do something, then we know whose door to tap. So he makes sure that'll happen. We have tried to change the way we want to run the course in 2021 as against how we did previously. We want to do 12 days of online learning through live Zoom events. This we thought would help all of you to not have to lose your days. You can do your work as you require and then carry on learning what needs doing. In line with what Nigel explained, finance is an issue, and so we make sure that you don't lose out on too much. And with 12 days of online learning, you have 4 days of intense practical sessions, which is a whole day of proper practical sessions coming from how to prepare your patients, scrubbing up, photography, hands-on on models, live placements on patients, patients that is provided at the practice, patients that you guys can bring in, and digital workflow, how to use a surgical guide, dental lasers, which is something that most courses don't even get into, but this is something that we have specialized at Dental Roots and we are getting into in more detail because that's the future of dentistry in a lot of aspects. And to end it all, you have a wonderful date with Nigel to sort of summarize everything up and get his expertise and experience in the way you guys progress over the next 6 months to 8 months. I hope that sort of gives you a good idea of what the whole course is about. And guys, the best thing is probably you will all have the question, oh my God, okay, that looks super cool, but what does it cost? I think the price probably is the coolest thing. And the reason why we are able to do the whole lot at such an amazing price is thanks to all the wonderful speakers who are on the course. They have looked at this training program as their support towards the general dental practitioners all over the UK to give them some kind of a stepping stone to get into good quality dentistry so they all can start to progress and be able to be the best in what they do. So I think I would have summarized things up as well as I could possibly do. You guys can visit the website at www.dentalroots.org. You can also email us at hello@dentalroots.org. We are going to send you emails following this program. And if you guys have any questions, Nigel will be extremely happy to take the questions on to sort of see if there's something that you guys like to listen to.
If you could rephrase that as extremely happy, depending how difficult the question is.
So they understand that now. But is there any questions, guys? No, I think it's been nice and clear for everyone. So with that summary in place, I would thank Nigel from the bottom of my heart for taking the time out from his busy schedule, especially on a Friday evening, and then making this webinar such an amazing event. There's so much for me to learn, and I'm very sure the rest of the panelists have enjoyed it as much as I did. It's a special thanks for Chris to be able to manage and organize all the aspects of this course as well as today's webinar. Jay on the back end looking after all the IT side of things, and Senthil and Darshan are always there to make sure things work nice and smooth. So guys, it's an amazing day today. So wish you all a nice weekend as we go forward. And we would hope to hear from you. If at all you have any questions, please email us. Anyone who's interested in joining the course can get onto the website and register themselves, or leave us an email or contact us and we'll help you in doing so. Thank you very much and have a good evening.
Thank you.
Thanks a lot. Thanks, Nigel. Thanks a lot.
Thanks, Nigel.
Thanks a lot, Nigel. It was an excellent lecture. Thank you.
And
it's much easier, which is slowly done in this policy to So that is how you have to
need to make it glamorous as well.
There's a gap there. So that the gap will be a very good team set up for myself.
Just high again.
Thank you, guys.
See you guys.
Thank you.
Bye-bye. Bye.
Bye.
Bye-bye. Have a great weekend, guys.
Thanks,
Thank you very
Chris.
much.
Thanks, Chris.
Cheers.
Thanks.
Bye-bye.